And actually, your talk is a very good segue into my talk. So this is Miss Rachel, and I came across this case actually less than 10 days ago. So she comes in complaining of shortness of breath, a little bit of chest discomfort, not so much, but it's been ongoing for a week. And we get an EKG, and yes, there are a lot of abnormalities, some depressions, maybe a slight hint of elevation. And then we get labs, and her hemoglobin comes back at 7.1, and I don't have a baseline. And I do a quick hemocult, and it's positive. And so now, if I call my cardiologist with my concern, what am I going to hear? Transfuse her, admit her, we'll see her again. It's subendocardial. It's not because of a STEMI, right? So my question when I was evaluating Rachel is she actually having a type 1 MI? Are these changes because she's actually, having an MI versus is this type 2? Is this an occlusion that needs to go to cath lab? Or is she having a supply-demand issue where if I transfuse her and hike up her oxygen supply, she'll do good? So here's what I did. I got my echo. And this, in her, she doesn't have any cardiac problems in the past, you could see here what we call wall motion abnormality. And this is very, very sensitive for ischemic events. So she ended up going to cath lab. After I told the cardiologist, by the way, I'm seeing wall motion abnormality, that's the only reason he took her, and she ended up having a 99% LAD occlusion. So I'm going to talk to you today about the walls between us. Please notice the us stands for ultrasound. I thought that was smart. So why do you need to echo every patient who comes in with chest pain? Because wall motion abnormality is the first clinically evident sign of ischemia. It is more sensitive than EKGs, sorry, Emil. And then normal echo, so if you have a patient who's actively having chest pain, and you throw the probe on them and they're absolutely normal with no motion abnormality, look for something else. Look for non-ischemic causes, right? So let's talk a little bit about what that means. So this is a normal parasternal short view. And what I want you to focus on is not just the movement. Yes, beautiful concentric movement, simultaneous. I want you to look at how the myocardium or the muscle thickens and thins and thickens and thins with every contraction. And that is what you need to focus on. If that is abnormal, that is wall motion abnormality. I'll show you. And then the other thing I liked is that if you're looking at your screen, your ultrasound screen, just put your finger in the middle or a pen, and you want to see the walls of the myocardium concentrically move towards your finger. And that kind of just helps you visualize if there's any abnormality. So let's take this image. You can, oh, sorry, how do you scroll back? There. You can see definitive wall motion abnormality in the septal lead. There's also global hypokinesis. It's not concentrically squeezing nice, right? And exactly just like EKGs can tell you which vessel is affected, echoes can do the same thing. And so I thought this was a little bit complicated, so try to simplify it. So in a parasternal short view, you could tell based on where the abnormality is if your lesion is in the RCA or LAD or in the circ. Now I got this from core ultrasound, which is great. I further tried to simplify it a little bit. And so if you have your RV, the wall next to it would be your septal wall, right? And the septum is divided into two. So the anterior part of the septum is LAD. The lower part is the RCA. And then the rest of it is circ. And it shares circ and LAD and circ and RCA. But ultimately, it really doesn't matter if you call your cardiologist and tell him, I think he has an LAD lesion. If you just tell them they have wall motion abnormality, that should be enough. So let's take a look at more examples of what wall motion abnormality looks like. So again, notice that the lower part of your screen is the muscle is squeezing nicely, whereas the highlighted portion in pink, there's not much movement there. There's no thickening and thinning of the myocardium. Take a look at this. So this one, you can see on the septal wall, which is next to the RV, not much movement going on there. Here, you can see the entire myocardium, all aspects of it, getting thicker and thinner and squeezing nicely. This is a normal parasternal short. If you do a parasternal long, you can also tell by looking at the muscles. Same thing, thickening and thinning. This is just a different view. This is what a normal one looks like. Notice that the thickening and thinning of the left ventricle, of the right ventricle, of the septum, this is all normal. Look at this. You can see some movement in the base, not much elsewhere, right? That's the only part that's getting thicker and thinner. The rest of the myocardium is just not, there's no thickness or thinning right there. If you get an apical four-chamber view, you can also determine the same thing. Wall motion abnormality, you look at the thickening and thinning. Again, each wall corresponds to a different vessel, but whether you memorize it, whether you have this as a reference, ultimately, I just want you to be able to diagnose that there is an abnormality. So if you look at this, you can notice that the ventricles are squeezing nicely, the walls are thickening, there is no abnormality. When you look at this, you could see that the bases are squeezing, but the apex is not doing anything, the highlighted portion. Same thing here. There's thickening and thinning in the bottom part, not much on the top part. Another example. And when you see that, when you see the apex not moving and it's kind of ballooned open, this is what we call Takotsubo's cardiomyopathy. Just so you're more familiar with it on echo. Take a look at this. Now, notice the lateral wall on the right side of your screen, how it's thick and thin and squeezing nicely, whereas, the septum is not doing much. See that? All right. So there are some caveats to this. So patients with prior MIs, prior old lesions, it's really hard to tell if this is old or new. So it's important to know what their previous echoes are. In my case with Miss Rachel, she had no cardiac history, never got an echo, never had an MI. So for all we know, her previous echoes should have been normal. Any patient with an existing LV dysfunction, so those with heart failure, it's also hard to tell because there's also global hypokinesis or dyskinesis. And then there's always the challenge with every ultrasound is if you're getting poor windows, whether it's due to the body habitus or the patient's just breathing too fast and you can't get nice windows. I put this up there because I like it. So the AHA guidelines for managing unstable angina or NSTEMI recommend Class 1A recommendation, early invasive strategy for those patients with elevated risks for cardiac or clinical events. And one of those risks is abnormal findings on echo. So this is why I'm stressing you have to echo every patient who comes into your ER with chest pain. I have this on my phone as a reference. You guys have a copy of the slides. You can take this. It just helps you kind of know which vessel corresponds to what. But as long as you diagnose the thickening and thinning, you should be good. And if you call your cardiologist saying, hey, this is new, her last echo was normal, or the patient never had an MI, and now I actually see wall motion abnormality, that is concerning for ischemia. Thank you.
All right, Leen. You don't have to leave yet. There's always a question.
Sorry.
And I know you went over this a little bit, but it's the end of the day, and I think it's probably one of the most important concepts. But how do you tell if it's old or new wall motion abnormality?
You don't. It's really hard to. You can if you have their old echo and you know how bad the hypokinesis is, if it's worse now, maybe. But really, if you're just looking at the abnormality where it's thickening and thinning, you really can't tell if it's old or new, unfortunately.
So do you tell the cardiologist about the old echo or just tell them there's wall motion abnormality?
This is just take them. But anyway, I mean, if a patient does have abnormality, they are more at risk for ACS and or MI, right? So that actually should push them to take them to cath lab and or investigate them more because they're already a high risk for ACS or acute MI.